Good afternoon, everyone, and thank you so much, whether you are watching this recording in the future, and to all of you who have joined us live today, thank you for participating in our virtual event series. Lions Vision Services is very excited about this year's event series because we are focusing this programming specifically on the topic of diabetes. Diabetes is a frequent contributor to eye conditions and is something that we see in a number of our clients. It's also, in some cases, a condition that is manageable and preventable if we encourage public education, awareness, and healthy lifestyle choices. So to begin our diabetes event series this year, we're excited to have Iris McDuffie with us to talk to us about healthy nutrition and dietary lifestyle choices that will contribute to diabetes prevention. Iris McDuffie is a registered dietitian nutritionist with over 16 years experience in clinical nutrition. She is the founder of Nutrition I Am LLC, a nutrition consulting business dedicated to providing nutrition counseling for individuals diagnosed with chronic disease states. Iris considers herself a clinical community nutritionist with expertise in renal nutrition. As the new Clemson and Rural Health and Nutrition Agent for Florence and Marion Counties, Iris is on a mission to teach individuals how to eat a healthy, balanced diet. Her focus is increasing awareness about chronic kidney disease and what you can do to reduce the risk of being diagnosed. Her most recent interest is social determinants of health in rural health communities. Iris is a member of the National Academy of Nutrition and Diabetes, Renal Practice Group, National Council of Negro Women, and Zeta Phi Beta Sorority Incorporated. Iris graduated from Elizabeth City State University and earned a Master of Science in Clinical Nutrition from the University of Arkansas for Medical Sciences and a Master of Science Education from Wake Forest University. Between work and her passion for educating the community, Iris enjoys cooking and preparing gourmet dishes, according to her friends and her beloved brother. Iris, thank you so much for joining us today. Just as a reminder to our guests, if you have questions for Iris, we welcome you to submit those through the question feature of the Zoom meeting here, or send them to us through the chat. We will be collecting that information and having a question and answer period at the end of today's program. And we'll also be sharing some exciting resources and upcoming events that Iris and the Clemson Rural Health and Nutrition Services will be leading. So Iris, thank you. Welcome to the program, and we're so excited to have you with us today.
Thank you for that awesome introduction, and I am excited about being here. This is definitely a passion of mine, and I'm always willing, ready, and available to share my expertise and also make sure that information is provided to the community. So today my topic is diabetes prevention, healthy nutrition, lifestyle solutions. So we're going to discuss, for some it may be a review, for others it may be an introduction, and for others it could even be a clarification of some terminology associated with diabetes, how we can lead a healthy life if we've been diagnosed, and or how we can prevent the diagnosis of diabetes. The objective today would be to define prediabetes, to list the 3 types of diabetes, to distinguish the difference between type 1, type 2, and gestational diabetes, identify who is at risk for diabetes, and identify conditions that increase your risk of being diagnosed with diabetes. So let's start by pulling up your phones and select your camera application, aim your phone or your camera at the QR code on the screen, and let's check your knowledge to see if you are a candidate for prediabetes. So let's take the prediabetes test. I'll give you a few minutes, please. Once you select the QR code, it's a yellow link will show up, a little bar that will take you to the test. When you finish, you can give a hands up or a clap or whatever you like for us to know. And then Daniel can give me the clue to go ahead and get started.
Sure thing. I just finished it myself, and we'll look for a couple other notes from our other attendees, and I'll let you know when we're ready to move on.
Okay.
That's a really good test, Iris. I learned a couple of things along the way. I like how responsive it is.
And I love these introductory type tests because sometimes it kind of sets the stage for, tuning into what you're about to hear. And also it gives you a foundation for what you may not have known about yourself or may need to know, really.
Absolutely. It looks like all of our participants live today have completed that test. So I think we're ready to move on.
Okay. So my next slide is an infographic on prediabetes, and it simply says it could be you. And if you've taken that test from just the conversation or the chatter that has been generated, you may have indicated that, or it may have indicated to you that you may be a candidate, or it could be just information where you've learned a little bit more about this term prediabetes. There are 96 million individuals or Americans, adults more than 1 in 3 that have prediabetes. Of that, there are probably a good many of those too that don't know that they have prediabetes. So we're going to look at how that diagnosis is determined and what you could do to prevent it turning into a full-blown disease state known as diabetes. So prediabetes by definition, as I said, is when you have, there's markers that they use to determine whether or not you have elevated blood sugars. And if you have a hemoglobin A1C greater than 5.7, I think it is, or 5.6. Nonetheless, those are the two markers, and pre simply means that you have potential to have a diagnosis of diabetes. Now, at this point, it really is an opportunity for you to plug into those lifestyle changes that will definitely totally erase this potential pre-diagnosis. Even if you've been diagnosed with prediabetes, you can actually change that such that you don't become full-blown diabetic. So I would like to say that if you've not had that conversation with your healthcare provider when you get your 3-month, your 6-month, or your yearly checkup, it's important that you take the initiative to ask that question to your provider to say, hey, what do my blood sugars look like? Can you check to make sure that I am not pre-diabetic? And if you have a family history, that's an even better opportunity for you to have that conversation so that you can kind of look at where you fit into the genetics of this whole scheme of things. So what is diabetes? We know that prediabetes indicates that you have the potential to have a diagnosis of diabetes, but by definition, diabetes is a disorder characterized by the impaired ability of you to metabolize carbohydrates, fat, and protein. Those are what we call your 3 major micronutrients that help to build the integrity of the body as well as maintain the integrity of the cells. It is often quite discussed and stated that if you have diabetes, you have to watch your intake of carbohydrate, but you really have to watch your intake of carbohydrate, fat, and protein, because all of those eventually have the ability to be metabolized, and from that you can gain sugar from those items. So it's important that we have an understanding of that. So when we look at the types of diabetes, there are 3 types. And the first one is known as type 1. Type 1 represent about 5 to 10% of the number of cases that exist. And it used to be referred to as juvenile diabetes, but now since, not sure of the time frame, but juvenile diabetes is no longer an acceptable term, because juvenile means that you are underage, if you will, or could be child or young adult, what have you. In this case now, you have type 1 individuals who are actually adults. So the term juvenile diabetes is no longer in existence because it indicates that there's a certain age range, and now that age range has increased to that of adults. By definition, these individuals make little or no insulin, so they are totally insulin dependent. Simply said, they have to have insulin in order for them to maintain and survive. These individuals usually can carry or wear these devices that will eject, if you will, the insulin or inject the insulin as the body indicates that those blood sugar levels are low. And these individuals are oftentimes referred to as conditions that are autoimmune. Simply means that they have the ability to make the actual protein or the hormone itself, but the good cells have actually started to uptake and affect the good cells that produce insulin are being attacked by your autoimmune system. Therefore, it's unable to produce that insulin. So you have to have an assistance, if you will. So these individuals make little or no insulin, but they have to produce adequate amounts by receiving it from a device or actually taking the shot itself. The opposite of that would be type 2, and this is where 90 to 95% of your cases are type 2. And this usually is associated with individuals who are of the adult age. You'll probably see some of the literature that will give you a range of between 40 and 45 years of age when they start to detect this. And also with type 2, just as type 1, type 2 now has been shown to be very commonly diagnosed among young children as well, especially children who may have a issue with obesity. So if you look at the trends, what used to be the trend for type 1, as we said, juvenile diabetes, it's now being a trend for all grade age groups. And now type 2, which it being the dominant form of diabetes, is now a combination too of adult and children. Your body produces insulin in the case of type 2 diabetes, but for some reason, it may not produce enough of it, or the amount that's being produced becomes what we refer to as insulin resistant. So in other words, those cells are not able to identify the presence of the insulin such that it uptakes the amount of sugars that are being made available. And that could be related to diet. It could be related to just the condition of the disease state itself. And then lastly would be gestational diabetes. This is the intolerance of sugar during pregnancy. And it's recommended that if you have a history of being overweight or a BMI greater than 30, that indicates that you are high risk for gestational diabetes, and or if you've had pregnancy or pregnancies where the individual or the newborn was greater than 9 pounds. So all of these are your risk factors that can increase that gestational, which only occurs during that physiological state known as pregnancy, which would allow you to be a strong candidate or a high risk for type 2 diabetes. So when we look at type 2 diabetes and we compare it to the normal individual and a pre-diabetic, the roadmap here shows us that if you have a hemoglobin A1C of 6.5 or above, if you have a fasting blood sugar test that's 126 milligrams per deciliter or above, or if you have a blood sugar that's greater than 200. So that's for diabetics, okay? And then if you're pre-diabetic, as I said, 5.7 to 6.4 would be the range for the hemoglobin A1C. If that blood sugar is 100 to that of 125, or if it's higher than 140 to that of, I think it's, can't see my screen here. But you can see that range there. So the pre-diabetes is the marker that tells us whether or not you're at a greater risk for developing a diagnosis of diabetes. Diabetes here indicates what we've used to determine that you actually have the disease state. And then of course, the last one, the green area there, would be an indication of normal blood sugars. And your hemoglobin A1C would be those tests that they do every 3 months. And that particular test tells us what or how much of blood has been elevated, how high your blood sugar has been over the last 3 months, in conjunction with what those blood sugar level ranges are, fasting, and then what that is post a meal after about 2 hours. So when we do a diagnosis of prediabetes, as I said, a fasting glucose of greater than 100, but less than 125, and hemoglobin A1C between the ranges of 5.7 and 6.4. And then a oral glucose tolerance test where your blood sugars is between 140, but less than 199. Okay, again, this is where we want to stop here a minute and say we can park the truck or the car here and say these are actual lifestyle changes that one can make that will automatically eliminate the possibility of you being diagnosed with prediabetes. And one way to do that is to watch your diet by eating a well, healthy, balanced diet with fresh fruits and vegetables, eliminating the amount of sodium, monitoring your cholesterol and so on and so forth, and then keeping those hemoglobin A1C levels within that range, less than 5.7. Diagnosis of type 1 diabetes. Primarily, we do a random blood sugar test, and if that blood sugar test is greater than 200, then that's an indicator. And then a secondary or a confirmation or validation, if you will, would be the hemoglobin A1C. This again is the type of diabetes that where individuals make little or no insulin, and it once was called juvenile diabetes, but it's now found to be common among adults as well. A diagnosis of type 2 diabetes is where your fasting glucose levels would be greater than 126, as you just saw on the roadmap there. Your hemoglobin A1C is greater than 6.5, and your 2-hour oral glucose test is greater than 200, and a random glucose test as well greater than 200. So it's been said that you probably want to do a combination of tests, such as the fasting glucose, the postprandial, and the hemoglobin A1C to validate, because hemoglobin A1C sometimes can be skewed depending on how that sample is collected. And then a diagnosis of gestational diabetes. First, they do an initial glucose challenge test, and then they repeat this test to determine if the diagnosis is accurate. Usually, most of the time, this is during pregnancy. And as I said, once the pregnancy is over, most oftentimes the body will reset itself and those blood sugar levels will resume back to normal. However, those blood sugar levels continue to increase over a period of time, and this would be post delivery. Then those are some telltale signs that you would want to consider having that conversation with your doctor and being proactive, and also making those lifestyle changes. And if you have a risk factor such as family history, overweight, BMI greater than 30, that's also other indicators that would for sure be an indicator for you to look at keeping a routine look at those blood sugar levels. So the glucose intolerances that first occurs and or is recognized during pregnancy increases your risk of gestational diabetes. And the research says that the incidence highest within the first 5 years after pregnancy. So again, if you have a family history, if you're overweight and you've had gestational diabetes, and that individual that was born as a result of the pregnancies is greater than 9 pounds, that's also an indication. So those are things that you probably want to pay close attention to, and it's easier said than done, but it's definitely something that you want to make sure you keep a running tab on. Okay, this is just a few fact sheets. And the reason I want to kind of hang around in this lane a while, because in this current state that we're in with COVID, and we're coming out of the pandemic per se, but there has been a lot of studies that suggest that if you had COVID-19, that it's very likely that you're likely to be a candidate or at risk for diabetes type 2, simply because COVID had so much of the issues with increasing the chance of inflammation and changing those bodily physiological changes that could lend itself to things like diabetes. And also in that space that we were in, there were individuals who actually had elevated blood sugar levels, whether they were at the level of gestation or if they were just individuals in general. But because they were not considered emergent issues, they were not seen by your healthcare care providers, because for the last 2 years, we only dealt with those individuals who were COVID and what we call urgent and emergent conditions. So if you had things like elevated blood sugar levels or hemoglobin A1C, or in some instances, physicians were just not even checking those kinds of things unless it was considered an emergency. So you have individuals that may still be carrying around some of those signs and symptoms and may not have known it. But here, previous history of gestational diabetes, as I said earlier, previously elevated blood glucose levels, maternal age is greater than 40, family history of diabetes, that is the first degree relative, sister, brother, mother or father, body mass index of greater than 35. I say if it's 30, that's already at the obese level. So you may want to start looking at it that way. And this is to kind of offset the potential of any damage that has potential to be done. And then a baby that has a weight of greater than 9 pounds at birth, and polycystic disease. And then there's some other medications that also may contribute to that as well. And it could be one or two or a combination of the two of those. Okay, these are just some infographics here that kind of reiterate what I've said before, but wanted to kind of bring your attention to what those risk factors are, and those risk factors that we have absolutely no control over, as well as those risk factors that we can make some lifestyle changes, and it could really affect the outcome in terms of us being diagnosed with diabetes. Okay, so genetics. That's something we have absolutely no control over. We didn't ask for who our mom or dad was, so that's something we have to deal with. But then you want to know that family history, and it's also important that you find out whether or not there's a family history, because that's good to know, because that tells us whether or not we are at risk. Physical inactivity, that is the ability to have an exercise regimen in place on a regular basis. If you're looking to just maintain weight and not lose weight per se, then we're looking at 150 minutes per week, which is about 30 minutes per day. BMI, knowing what that level is. If you have a BMI greater than 24.9, which is considered overweight, and then you start moving towards that of 30, that's that level of obesity. A family history, as I said, age, at age 40 to that of 45 would be the adult onset, but in this space that we're in right now, with us having been closed in, if you will, isolated, and not having the ability to go to the gym, if you will, and not being creative in terms of how we were able to incorporate that physical activity, it may be that that would be a contributing factor as well. I guess you could say elementary to that of middle school age individuals are quite often, it seems, at risk for obesity, and definitely in the space that we were in where they were home alone, if you will, and left to their own devices and were pretty much eating whatever they wanted, and definitely not picking and choosing the best food items. So all of those things. And so that is a lifestyle change that can be definitely an effective means of making sure that we reduce our risk. And then, of course, as I said, gestational diabetes, and of course, ethnicity. So that would be African American, Asian American, Pacific Islanders, and Native Americans that make up that population that are at increased risk based on ethnicity and or race. Okay, I wanted to kind of park here a minute too, because health literacy levels is very important. Now, all of that, the aforementioned information that I shared with you, knowing the language and understanding the language can also be a barrier. We know diabetes to be the term that refers to sugar or having elevated sugar levels, but do we know what organs are functional in making sure that we have that normacy? So pancreas would be the gland that produces the insulin. Insulin can be delivered, if you will, by way of a shot, some people say, or needle, knowing that insulin is the hormone that regulates your blood sugar levels, and how that works in terms of us eating a meal. And hemoglobin A1C, terminology that's used at the doctor's office to assist you with telling you what markers or labs they're looking at, but understanding what that means and what it means in terms of your situation. Do I have type 1? Do I have type 2 diabetes? Do I have gestational diabetes? What is the difference between those two? How did I get it? What do I need to do to manage it? So diabetes knowledge, self-efficacy in terms of feeling confident about the disease state I've been diagnosed with, knowing enough about it to know what I need to do. And I would take it a level beyond that, a step above that would be to make sure that we know the right questions to ask and feel confident in asking those questions. And then just making sure that the terminology is being used, that before we walk away from that healthcare provider that has introduced us to a new term, that we make sure we walk out knowing what that term means and what we need to do to make sure that we are in control of taking another level of self-management. So health literacy is very, very, very important. And most of the time, you have very low literacy levels for individuals who have these chronic disease states. Socioeconomic status can have an effect on that. Rural areas, literacy levels in terms of education and things of that sort. So having knowledgeable understanding of what it is that you're working with has a lot to do with what those outcomes will be. So what are the organs affected by elevated blood sugars? Kidneys is one of them, the heart is one, the nerve is another one, and then your eyes. So organ damage, when it relates to the different organ systems I mentioned, having an understanding of how it gets to become damaged, if you will. Well, it's all at the level of the blood vessels. When your blood sugar levels are high, or when you have hyperglycemia, which means elevated blood sugars, these blood sugars play havoc on these various organs. So they cause damage to the internal lining of the organ itself, which would be the blood vessels. And as those blood vessels become weakened, then they're unable to perform the duties and responsibilities they have been assigned. So eventually with your eyes, you'll start to have blurred vision. And that blurred vision may start at a very basic mild level, become somewhat mediocre, if you will, until a point becomes severe. And eventually you start to lose your vision. Second would be your heart. Your heart is related to blood vessels because the heart is the one that delivers the blood throughout the entire body to various parts of the body. And so if your blood vessels are damaged again, it puts you at a greater risk for stroke and heart attack, also cardiovascular disease in general. And I would love to be able to tell you that this one happens first, that one happens second, and something happens third or fourth, but once it's been exposed to those elevated blood sugar levels, it's hard to determine which one comes first, chicken or egg. So it's just a good idea to be very cognizant or aware of what's happening so that you can take those necessary measures to prevent any of those organ systems being affected. Your feet is another one. When you have elevated blood sugars or uncontrolled diabetes, when you get lacerations or you get foot sores or things of that sort, because of the blood vessel damage, the inflammation increases, you get inability of those ulcers to heal, infection sets in, and then you got another set of problems. Where there's a blood vessel, there's always going to be a nerve. And so nerves actually get damaged from elevated blood sugars. And eventually you have what we call diabetic neuropathy. And then lastly, you have kidney, and not last, but next you have kidney diabetes related, and that causes nephropathy. And so again, those blood vessels within the filtering process of the kidneys are very, very, very small, but they have very powerful functions and obligations and duties. And when those blood sugar levels are elevated on a regular basis, sugar is a very large molecule. So for the ability for it to move through those blood vessels, it plays havoc on the kidneys, which eventually causes kidney failure. And so now you got a risk of kidney failure, you got heart disease, You got blurred vision that leads to blindness. You possibly could have infection because you're not getting adequate blood supply to those lower or upper extremities. And then lastly, you have ears. Your ears actually have blood vessels in those areas as well. So they can do damage to your ability to hear. So over a period of time, eventually those elevated blood sugars can have some very adverse effects on major organs. And the only way that you're going to be able to improve upon correcting those, if you will, in most instances, is to either have that particular organ structure removed in case of the feet, or you run the risk, again, as I say, of stroke or heart attack, and or which could be life-threatening to a point that it causes death, or it could be life-threatening to a point that you are left in a very debilitating state, such as paralysis. And then with your kidneys, eventually, once chronic kidney disease sets in, it becomes progressively worse, such that you have to have dialysis. And of course, with your ears, if you lose the ability to hear, then you have to have hearing aids. And then, of course, with your eyes, it would be blindness. So did you know that people, as I said, are again at high risk of cardiovascular disease or heart disease simply because of the aforementioned? So diabetes and heart disease are very closely linked, and they're linked simply because of the damage that is caused through the blood vessels. And it could be inflammation of the blood vessels, the thinning of the blood vessels, and over a period of time, as the blood is being transported that 60,000 miles all over that entire body to get to various parts of the body, it causes insufficient amount of blood to reach those designated areas. And eventually the end result would be stroke and or heart attack. So when we look at eyes on diabetes and what really happens here, we're looking at how important it is for us to make sure that we understand that diabetes is a leading cause of blindness, is the leading cause of heart disease, is the leading cause of kidney disease. A large percentage of individuals who lose their sight to blindness because of diabetes, simply because they've had very poor, if any, eye treatment. So we want to recommend that you have your eyes checked on a regular basis, and that you get treated for diabetic retinopathy if you know that you have diabetes, to prevent vision loss. And we also recommend that you check out that family history. Again, that's very, very, very important. Regular eye screening begins with primary healthcare professionals, and making sure that you have the optic nerve checked, and all of those things with going along with that for making sure that we're acting today to change our future for tomorrow. There's some 415 million adults with diabetes, and some 600 million adults they expected by 2040, I think it is. So those trends are increasing. And as I said, with COVID, they're predicting that because of the huge amount of inflammation that came with COVID, that they're suspecting that this inflammation is going to affect the onset and development of diabetes. So here again, if you don't have a family history of diabetes, it's important that you make sure you have those regular checkups, and you ask those significant questions of your healthcare providers to make sure that you're in check with what's going on. You understand what it is that they're recommending that you do, and you check those values and those numbers to make sure that all those things are within normal range. And once you start to see any of these changes, especially the blurred vision, and you know that you've had a diagnosis or you have elevated blood sugars, those are things that you need to pay close attention to, because again, we're not sure when that damage starts to begin or when it starts, but we do know that a lot of times by the time that we've gotten the diagnosis, it didn't start yesterday. It's been ongoing for some time. And a lot of times we've been aware of it, but we just thought it was everything but what it truly is. So just having those conversations and making sure you stay on top of your healthcare providers, and you follow through with what it is that they're asking you to do. And then lastly, which is my area of specialization, is diabetic nephropathy, and that is the effect that diabetes can have on the kidneys. The kidneys are very, very small structures, but they have a very powerful function. And again, when you look at the inside of a kidney, it has little tubules that look kind of like ramen noodles. And so in those tubules is where you have the filtering of all of the blood that comes from the heart, and it takes it to the kidneys, and the kidneys say, okay, this is what I need, and this is what I don't need. So when it starts to filter, it's filtering in competition with those very high levels of blood sugars. And remember, sugar is a very large molecule. So if you look at and able to mentally identify what those ramen noodles look like, that's a very small structure for a large molecule to go through. Now, it's able to do that under normal circumstances, but when those sugars become elevated and they stay elevated for a period of time, that means you're having an excess of blood sugars that's having to be floating or filtered through that process. So that's where the damage of your arteries and veins come on. And when that damage of those blood vessels occurs, it also puts a whole lot of excess work on the kidneys, because it's designed to filter, and it's going to try to filter. It's going to try to filter whether it's large or small. But when you have those elevated blood sugars, that's something we control by making sure that we're not putting any more on this structure than it is capable of bearing, if you will. Okay, and then lastly, diabetic neuropathy. This is nerve damage. Anyone who has diabetes is very likely to have nerve damage. And the factors that can increase your risk, again, here again, blood sugar levels that are hard to manage, having diabetes for a long period of time, especially if your blood sugars are higher than your target levels, being overweight, being over 40, having high blood pressure and high cholesterol. So again, cardiovascular disease and all of its kit and caboodles of everything that can go wrong there plays havoc on your nerves. And eventually, when that nerve damage occurs, it causes one not to be able to feel and to have the sensation of knowing that they've actually stepped on a nail, or they've actually damaged a toenail because they cut it too close. Because eventually, nerves is what gives us the ability to feel the sensation. When those nerves are damaged, you have no sensation at all. You know you have legs, but literally that's pretty much it. So most individuals who have this, they've had these issues for some time. And then over a period of time, eventually the ability for them to identify or to feel or to have the sensation is lost. So that's where you have those individuals who eventually have to have amputations because the blood supply is insufficient, and also the ability of the sensation to be detected is no longer there because of the damage as a result of your blood sugar levels, in conjunction with everything else we've mentioned there too. So again, it's difficult to say which one came first, chicken or egg, but if you have any of those aforementioned risks there, the damage starts when it starts, and over a period of time, it gets worse. So what can we do as healthcare providers? Number one, avoid clinical inertia, and that is to make sure that when we're seeing our healthcare provider that we ask those questions. But as a healthcare provider, we want to make sure that we take the initiative to start the intervention to avoid the diagnosis of, in this case, diabetes, if it's not a case of diabetes already, and or if there is a case of diabetes, that we start the whole process and treatment so that we can eventually affect and reduce the incidence of some of those other risk factors that can be other matters that further complicate the issue, such as kidney disease, and you end up on dialysis, or heart attack and or stroke, the neuropathy such that you have to have an amputation, and or vision loss, and in some instances, ear loss as well. Take the bull by the horns. Treatment should be timely, and timely in a fashion such that if there needs to be a follow-up in 3 to 4 months, if that's what the physician has told you, you make sure you meet those timelines so that you can stay on top of those things, think outside of the box. Anything that you're not able to do as a provider, then you need to consult out so that you can make sure that these conditions and concerns are being addressed. A cardiologist wouldn't go to a nephrologist for his heart. He would go to a cardiologist for his heart. And likely so, a kidney doctor would not go to a cardiologist for his kidneys. So everybody has their lane, if you will, but you also have to collaborate with one another to make sure that the left hand knows what the right hand is doing so that we can make sure that we're treating the person as a whole. And communicating that information is also important too. And if you find that your healthcare provider is not doing that, you need to take the initiative, be proactive. We as educators, healthcare providers need to make sure that we're on top of our game by staying updated with education, making sure we have the necessary resources so that we can support and be an advocate for self-management. Involvement and inclusion, promoting dignity and care. And once these individuals have been diagnosed, that we need to impress upon them that they are not life sentences, but they do require some lifestyle changes. And those lifestyle changes would be for us as healthcare providers to make sure that we are providing solid evidence-based information, that we are holding ourselves accountable, but we're also collaborating with the other members of the team to make sure that the quality of care is very patient-centered. What do I need to do as a client and or a patient? Be proactive, as I said, ask lots of questions. Make sure you're armed with the information you need to provide self-care or at least start the process. Think outside the box. Request education, resources, and other means of self-management support. And that comes from feeling that level of self-efficacy, making sure that you're confident about what it is you need to know. And that comes from asking questions. It also comes from reading and researching and investigating what has been told to you and finding out what your level of understanding is. And if you don't read and ask questions, that level of understanding is going to be difficult for you to obtain because sometimes I believe we know by doing, and you don't do any better until you know better. But if you don't ask those questions, you wouldn't have an opportunity to even get to another level, if that makes sense. So long-term goals, as I bring my presentation to a close, would be to ask questions, keep your eyes healthy, journal your blood sugar levels. And the journaling of your blood sugar levels would only be specific if you've had some unusual changes. Know your numbers, know your weight, know your blood sugar, know your BMI, know your triglyceride levels, know your cholesterol levels, know what that weight is, and making sure that you're making strides to reducing that weight, and find out ways that you can actually obtain that information. It used to be that when you went to the doctor, they would give you a handout. Now they don't cut down any trees, if you will, so you're assigned to a portal. So make sure you have that basic knowledge of how it is that you need to access that information on the computer so you can know what those numbers are from one visit to the next, and then you can kind of track and see what those trends are. Manage your stress, whether it's chronic or acute. Maintain a healthy weight, prevent foot problems as much as you possibly can. And if you have foot issues, get it checked out and make sure that you're not accruing a different kind of set of problems. Seek information and stop smoking. Some of these, for the most part, are lifestyle changes and very basic things that we can do just to kind of keep track of what's going on. So my recommendations are, again, individuals who are overweight or obese should begin testing at age 35 to make sure that you're not at risk for cardiovascular disease. Also to make sure that you're not at risk for diabetes, especially if there's a family history. A diagnosis of prediabetes automatically warrants intervention immediately to further complications. So if you've been diagnosed with prediabetes, a lot of times the intervention now is for you to start with a diabetic medication, and that's to kind of regulate those blood sugar levels. But you can start with the weight regimen program to make sure you lose the weight, and also watch your diet and what you're eating. And then collaboration among healthcare providers and patient, make sure you establish that relationship so that you're able to answer those questions or ask those questions. And then implement an exercise regimen and keep it. A lot of times, some of these recommendations require that if you can't do it by yourself, that you seek a support group. And there are multiple support groups out there that are absolutely free. You just need to kind of do your research and find what program best fits for you, and find a program that's going to help you accomplish whatever that goal is as it relates to your health. Your health is your wealth, and it's only one lifetime that you're going to get, and how you choose to use it is totally, totally, totally up to you. So this pretty much ends my presentation about diabetes, but here I'd like to share with you, as the rural health and nutrition agent here for Florence and Marion counties, we offer chronic disease programming, and there are two programs that I train now. And the first one is No Diabetes by Heart. And this is a 1-hour session that we can offer virtually, in person, or as a hybrid. It's absolutely free. We need a minimum of 5 people to do the program, and a maximum of about 15 or 20, depending on the physical space. But 20 is probably the most we can handle to make sure that we're able to facilitate the program and maintain the integrity of the program itself. This class will show you the link between diabetes and cardiovascular disease. It discusses the risk factors in more detail. It gives you an opportunity to join the initiatives where you can get education, you can get resources. You have a Q&A period where you can ask questions of a subject matter expert, like a diabetic educator that's a dietitian or a nurse. And it just allows you to become very familiar with the concept. And this program was put together by the American Diabetes Association along with the American Heart Association. So it's a integral effort to educate you about taking advantage of your health. Again, that program is for anyone. There are no specifications. It's a 1-hour session. And then the second one is Health Extension for Diabetes. And this is a program that's 16 weeks or 4 months. And in this program, you actually have to be a candidate by way of having a diagnosis of diabetes. And in this program, you're going to target really serious diabetes education, which would include resources about medication, include information about nutrition, information about physical activity and what you can and cannot do. And the whole idea is to make you a self-supporter or a self-manager of the disease. Again, this is a 16-week program, and you are required to have a diagnosis of diabetes. And the program, you graduate, and we follow you for a month after graduation, 6 months after graduation, and a year, and so on and so forth. Both of these programs are a part of the Healthy SC, Healthy Me program. We have a joint collaboration or a funding by way of MUSC, and this is how we're able to bring these free programs to you. So it's a research program, and we're collecting data, but the whole idea is to peruse the community and make sure that they have the tools that they need to make sure that they're able to manage and support and maintain this disease state or disease states, or prevent from having the diseases. Okay, at this point, can you show that the list of the programs, because there are about 9 programs that we had. I just emphasized the 2 that I trained for right now. Daniel. Do I need to stop sharing?
I'm not able, my computer is not letting me attach that document to the chat. So what I will do, we're going to send all attendees the recording of this, and I will make sure that they have that as an attachment with that follow-up material.
Okay, that's even better. Yep. Okay, well, here's the evaluation. I'd like for you to pull those forms out one more time and click on the QR code and tell me what I need to do to improve this program. Information you may have wanted me to cover that was not covered, whatever. I'm here to serve, and I need to get some feedback as to how I can improve upon my presentation.
Well, Iris, thank you so much for sharing this information with us today. I just have to say it was very informative, very engaging, very thorough, and I think that you're going to get some really positive evaluations from all of this.
Oh,
I
good. Okay.
predict. So thank you. We do have quite a few questions that some of
Mhm.
which are in the chat and some that have been coming in. So I do want to use some of the time that we have left to get through as many of those as we can. The first of those that I'll start with is how low does glucose have to be for most people to lose consciousness?
Ooh, well, if you're hypoglycemic, if you have a blood sugar less than 70, but of course, it really depends on the individual, because we have to take in consideration, was this the first time that this occurred, or is this something going on for some time? And I like to use the term threshold. There are a lot of individuals who know the term hypoglycemia, but they don't know that they've actually experienced it. So it really depends. Some persons start off with a blood sugar less than 70, but 50 could be a number, 30 I've heard of, but that becomes an individual approach. And so if you're experiencing any of that, again, this is where those conversations with your physician is very appropriate, and they wouldn't know this information unless you shared it with them. But that's that self-efficacy and that health literacy, is knowing what to expect with the condition. And or if you're experiencing hypoglycemia and you haven't been diagnosed, those are things that you also kind of want to track and create a journal, because there's obviously something going on. You just need to figure out what it is.
Absolutely. Thank you for that.
Mhm.
Next question is there any evidence for why ethnicity plays such a role in diabetes?
Well, I think we can fairly say social determinants of health, the inequity in terms of access to healthcare, rural communities in general. I had the opportunity to work in a VA in West Texas, and I wouldn't have known this unless I experienced it, but we had individuals who had access to a VA facility. They were 90 miles from the closest facility.
Wow.
Some individuals didn't even know that this location existed. Some individuals who are veterans didn't even know that this was a service that was offered. So when you look at, it goes back to literacy, health literacy, not knowing accessibility or lack thereof, just that basic knowledge of what's going on with your body and who do I ask, what do I ask? So it's kind of hard to say, but I would say social determinants of health, which is a new term now, where we live, where we play, where we work, doesn't necessarily mean that we have access to everything that we need. And so when you look at racial disparities, you have to consider that sometimes that has what has occurred. And then for individuals who are not insured, persons really can't afford to pay for healthcare, so they don't see it as an option to go seek and see who can assist me with this. They just kind of contend with the idea that I can't pay for it, so I have to live with it, which is a terrible notion to have. But if that's your level of understanding, that's your mindset. And so that's what we want to do, is to educate and to make that information available, and to know that whatever your circumstance is, that if you bring it to us, we can take you to a location where you can get some of those resources.
Absolutely.
Mhm.
Iris, what are some techniques or strategies that you have found helpful for trying to help or to work with people who might be averse to testing or management of diabetes or pre-diabetes symptoms, but who you might see, either as loved ones or as friends or as family, might be predisposed or might even already be experiencing some of those issues? How can people, on a practical sense, navigate some of those hesitancies and help people get the care that they need?
That's a very good question, because again, it goes back to health literacy, but you have to work around whatever those idiosyncrasies or those levels of lack of understanding are. As a clinical dietitian, I run into that oftentimes. Persons are oftentimes fearful of not knowing. And so then they put up this barrier where I want to know, but I don't want you to know that I don't know. So then you have to create that opportunity for conversation. And one of the ways that I've done that is I've actually walked into rooms where I knew I had to provide an education, but the person was not willing to accept the education. So instead of me going in and telling them everything I know about nutrition, diabetes, or whatever, I walk into a room and I find something that's a common piece of conversation, an icebreaker. And you could do that with relatives. Common piece of conversation, and you get them talking, and then you just slide in some of those things you want to know. It doesn't have to be one of those situations where you're bearing them with so much information that they run when they see you, but just slowly kind of inch it in. And I'll give an example. I had a nephrologist who they said was very unapproachable. And, they just said, oh, stay away from him. So when I would need for my patients to have to get a supplement so that I could assist them with maintaining their potassium, phosphorus, or even just getting them to eat, I had to figure out a way that I was able to approach this physician. So he had silvery hair. It was beautiful. And he wore these nice shoes. So when I would see him on the floor, instead of running the risk of him telling me, I don't want to hear it, or, I don't believe in this and that and the other, I would wait till he sat down and I would walk up to him and I would say, do you have a minute? And he would say, yes, what is it? And I would say, I've been watching those shoes that you have on. Where did you get them? And that was my segue. And we'd have a conversation about that. And then I'd comment about the shirt or something else, just to kind of as my icebreaker. And I said, well, you know what, by the way, is such and such your patient? I think I saw him a few minutes ago. He or she told me they weren't doing this, that, and the other. Do you think while we're sitting here talking, you could write an order for him or her to get so-and-so? You got a meeting out of your hand. And that's simply because you were able to appeal to the humanistic part of them without the routine of, can you give me permission to give this patient this? You know what I mean? So you have to treat loved ones, you have to treat healthcare professionals, you have to treat everybody that way, the same way you would handle a situation where you've not been able to make good success. You have to learn how to walk around the issue and figure out a way to create that segue. If you are sincere about what it is you do, you'll figure out a way. And if it's a loved one, you'll have to, because you're interested in making sure that their well-being is a priority.
Absolutely. I think that's a great place for us to leave it, Iris.
Yes,
we have to be those advocates for our friends and our family members, and we can't forget the human element behind all that we do. So thank you again so much for taking the time to be with us today to share this exciting and useful and timely information with us. We're very grateful for your expertise with that. I would encourage all of our attendees to go ahead and mark your calendar for our next virtual event series, which will be on Wednesday, August the 17th at noon. And we will be talking about diabetes support groups and communities there. And the executive director of the Georgetown Diabetes Core Group will be our guest speaker at that event. So we will be sharing registration information about that with you all soon. And of course, if you have any questions for Iris, if you're watching this later, or if you didn't get a chance to ask your question today, feel free to email us at info@lionsvisionservices.org, and we'll be glad to get that information to Iris and get that response to you. Again, thank you all for participating today, and we look forward to seeing you at our next virtual event. Thank you.
Thank you.